Hello and welcome to my YouTube channel. So friends, today we will study about one important structure present in between the thorax and the abdominal cavity. So let's start. Here you can see the image where you can see the thoracic cage. Just below the thoracic cage, you can see this musculotendinous structure which is actually present in between the thoracic cavity and the abdominal cavity. So today we will explore this musculotendinous structure which is separating one cavity from the another, and this is known as diaphragm. So let's start the journey of diaphragm. All the anatomical aspects we will explore. This is showing the posterior view of the diaphragm. Here you can see the scapula, rib cage and below muscular part of diaphragm which is visible here. So further in this image you can see the superior view of diaphragm. You can see both sided muscular part of diaphragm. This is known as dooms of diaphragm, right and left dooms. Central part is tendinous, and you can see that some fibrous structure is present over the tendinous part. This is fibrous pericardium, which is covering the heart along with its pericardial cavity. So this is the fibrous pericardium and borders are cut part of fibrous pericardium. Just below this we will have the tendinous part of diaphragm. These are some important structures which are passing through the openings of diaphragm. Namely, you can see this is the esophageal opening, this is aorta passing through the aortic opening, and this is inferior vena cava which goes to the right atrium of the heart. So this is the superior view of diaphragm, how it looks like in cadaveric specimen. Further, this is inferior view of diaphragm. If you see the diaphragm from inferior aspect, on both sides you can see the muscular part and this central part trifoliate appearance, this whitish part looking like trifoliate appearance is the tendinous part of diaphragm. So here you can actually visualize the shape of diaphragm. Both sided it is muscular and in the center it is tendinous. So hope you have understood the actual structure. This is the muscular part on both sides and in center part you can see it is tendinous, trifoliate appearance of the tendinous part. So moving further, the topic is the diaphragm. Do you actually want to know the anatomy? So let's go further. Structure of the diaphragm. It has both parts, muscular as well as tendinous, which you have seen. Central part is tendinous and peripheral part is the muscular. Two dooms, right and left, you have seen. And labels of the parts of diaphragm is very important, which can be asked as MCQ questions. So the central part of diaphragm is actually at the level of Giephi-sternal joint, the articulation between Giephoid process and the body of the sternum. Giephi-sternal joint is the level of central tendon. Level of right doom of diaphragm is upper border of fifth rib. So right doom is actually at the level of upper border of the fifth rib, and while the left doom is lower border of the fifth rib. So from here you can see that right doom of diaphragm is slightly higher as compared to the left dome of diaphragm. So if one part is higher, other part is lower, there should be some cause for this. So on the right side in the abdominal cavity we have large viscera, that is liver, and on left side we have smaller viscera comparatively are the spleen and the stomach, so that right dome of diaphragm is slightly elevated as compared to the left dome of diaphragm. Hope this is clear to you. Let's move further. This diagram is very important. As we have discussed the levels of right and left dome as well as central tendon, but since the thoracic cavity pressure is changing continuously and diaphragm is moving up down, so the position of diaphragm is not static. It will change with the position according to volume of the thorax and the breathing activity. So in the expiratory position, diaphragm will be elevated, and in inspiratory position, diaphragm will be lower down. So the position of the diaphragm will change with the activity of respiration, or you can say breathing. And if you lie down, what will happen to diaphragm? It will move higher up. When you sit down, sitting position, diaphragm will be lower. So this is due to the gravitational pull. If you are sitting, all the viscera of the abdomen with the gravity will go slightly downward and diaphragm will also go down. But in supine position, the visceral pressures of the abdomen will cause the diaphragm to go towards the thoracic cavity. So in supine position, diaphragm will be slightly higher. So this is the positional change in the level of diaphragm. Now, diaphragm has many attachments. So how we will remember the attachments of diaphragm? So initially it is said as origin insertion, but nowadays we use the term attachment more appropriately. So origin of diaphragm is from many structures like sternum, costal cartilages, ribs, and the vertebra also. So since the diaphragm is at the level of Giephi-sternal joint, so it takes origin from the Giephoid process, posterior part of Giephoid process. Lower six ribs is related to the diaphragm, so they will also give origin to the diaphragm, mainly the inner surface. So inner surface of lower six ribs along with the costal cartilages. Now, vertebral origin is very different. Diaphragm directly does not take origin from the vertebra, but they have some crura, right and left crus of the diaphragm. Via that, diaphragm takes origin from the vertebral bodies. So, I will show you one picture where you will see the right side vertebral origin. Some muscular fiber is coming from the body of the vertebra, and again on the left side from the vertebral body it is coming. So these crura are important origin, vertebral origin of diaphragm, and it is different in the right and the left side. On the right side, vertebral origin takes from L1, L2 and L3 along with the intervertebral disc. But on the left side, it only takes origin from the lumbar 1 and lumbar 2 vertebra along with the intervertebral disc. Now, some muscular fiber also takes origin from the arcuate ligaments. So, what are the arcuate ligaments? Three arcuate ligaments are there. Median in the centermost position, Lateral to that we have medial arcuate, and more laterally we have lateral arcuate ligaments. So from these structure diaphragm takes origin. Finally, where they go? They go to the central tendon of diaphragm. So from all sides fibers are coming and finally going to the trifoliate central tendon of diaphragm. Moving further, actually in this picture you can visualize all the arcuate ligament and the crus of the diaphragm. So on the right side, this is the crus taking origin from L1, L2 and L3 lumbar vertebra along with the intervertebral disc, and finally going to the central tendon. This is the right crus of the diaphragm. This is the left crus of the diaphragm, only from L1, L2 along with the intervertebral disc. Now, when you see the posterior abdominal wall, we have two important muscles there. So this is psoas major muscle. Lateral to that we have quadratus lumborum muscle. So these muscles will have some coverings, epimysium, fascia, deep fascia. So actually the deep fascia which is covering these muscles will form some ligament due to thickening of these fascia. So psoas major muscle will be covered by psoas fascia, and the thickening of this fascia will form medial arcuate ligament. So this is the medial arcuate ligament, medial L. Quadratus lumborum is also covered by the fascia. So thickening here will form lateral arcuate ligament. So this is medial arcuate ligament. This is lateral arcuate ligament. Thickening of the fascia over these muscles. Now both side, right and left crus will also joined by one ligamentous structure, which is actually the thickening, and this is forming the median arcuate ligament, the central part, median arcuate ligament. So this is the crus and the ligaments from which the diaphragm will take origin. Sternal part, Giffard process, origin. Lower six ribs, you can see it is also originating from the lower six rib. Which surface? Inner surface, along with the costal cartilages. So this is the overall origin, and finally they are going to attach to the central tendon of diaphragm, this trifoliate appearance, central tendon of diaphragm. In this picture we can also see some major openings in the diaphragm. So this is vena cava opening, this is esophageal opening, and this is aortic opening of the diaphragm. So you can see here that vena cava opening is present in the central tendon of diaphragm. This is very important. Vena cava opening is present in the central tendon of the diaphragm, while the esophageal opening is present in the muscular part of the diaphragm. Which muscular part? This right crus is looping here and finally forming the esophageal opening. So actually the esophageal opening is present in the right crus of the diaphragm. And the aortic opening is not actually the opening in the diaphragm. It is present just behind the median arcuate ligament. So aortic opening is posterior to the median arcuate ligament. It is not actually within the diaphragm. So these are the three major openings which we can see here. Moving further, descriptively, we can say that right crus is taking origin from first three lumbar vertebrae and the intervertebral disc. Left crus taking origin from first two lumbar vertebrae and intervertebral disc. Medial arcuate ligament is thickening over the psoas major fascia. And how it is attached? It is attached to the body of L2 and to the transverse process of L1. Lateral arcuate ligament, as we see, thickening over the quadratus lumborum muscle, and it is attached to the tip of transverse process of L1 and to the lower border of 12th ribs. Now, what about the median arcuate ligament? It is joining both sided crus, right and left crus, or it can also join both side medial arcuate ligament. So this is about the crus and the arcuate ligaments. Moving further, what is the action of the diaphragm? So this is important muscle for inspiration. So when it contracts, thoracic cage volume will increase due to decrease in the pressure in the thoracic cavity. Means when it is going down, pressure inside the thoracic cavity will decrease, air will suck in and volume will increase. So this is the main action of the diaphragm. What it is causing? So when it goes down, the vertical diameter of thorax will increase, and when it goes up, vertical diameter will decrease, but it is also attached to the lower 6 ribs and the sternum. So when it contracts, the AP diameter and transverse diameter will also change, causing the overall increase in the volume of thoracic cavity. So it is acting as muscle of inspiration. Also, due to its contraction, the pressure inside the abdominal cavity will increase, and that will help in abdominal straining like defecation, micturition, all these activity. It will be helpful in those. It also acts as a weight lifting muscle. So when it contracts, abdominal cavity pressure will increase. It Due to the pressure, vertebral column will straighten up, and if glottis is closed, it will make a strength over the posterior abdominal wall that will be helpful for the weight lifter. So it acts as the weight lifting muscle. Finally, thoracoabdominal pump. So when it contracts, the abdominal, intra-abdominal pressure increases, and inside the abdomen we have major veins, azygous, hemiazygous veins, inferior vena cava. So pressure on these veins and inferior vena cava increases, so blood will be pumped towards the thoracic cavity, because inside the thoracic cavity pressure will decrease due to the contraction of diaphragm. So it will help as the venous pump. Blood will be pulled towards the thoracic cavity due to the contraction of diaphragm. So in this way it is acting as thoracoabdominal pump. Another thing, we have thoracic duct, which is arising from the cisterna chyli, and this cisterna chyli is again present in the abdominal cavity, and when the diaphragm contracts, abdominal cavity pressure increases and the lymph pulled along the thoracic duct towards the thoracic cavity, and finally it will go to the veins, major veins like junction of inferior internal jugular vein and the subclavian vein on the left side. So in this way it is acting in the lymphatic drainage also via the thoracoabdominal pump activity. Hope this is clear to you, the actions of the diaphragm. Moving further, innervation of diaphragm, nerve supply, that is very important. So it has motor supply and also the sensory supply. As everyone knows, I hope you all know, diaphragm means phrenic nerve. So motor supply of the diaphragm is via right and left phrenic nerves. Simple. And the root value of phrenic nerve is C3, C4 and C5. Simple. Now the phrenic nerve also has the sensory nerve fibers, and that will also supply the diaphragm. So central part of diaphragm is supplied by phrenic nerve, sensory supply, and the peripheral part, sensory supply, is carried via lower 6 intercostal nerves. So this sensory supply is quite very important. So if you have studied the referred pain, now think that if there is some irritation to the diaphragm due to any disease, the pain will be carried via these phrenic nerves because it is also supplying the sensory nerve endings to the diaphragm. So root value of phrenic nerve is C3, C4, C5, and dermatome of C3, C4, C5 is around the shoulder region. So if irritation happens to the diaphragm or inflammation or any disease, the pain will go to the right shoulder if involvement is on the right side, or it can go to the left shoulder if it is involved on the left side. So due to the same dermatome C3, 4 and 5 over the shoulder region, so referred pain due to the diaphragmatic disease can be caused to the shoulder region. Now, but if peripheral part of the diaphragm is involved, where the pain will go? To the subcostal region. So if there is pain in the subcostal region, again this can be caused due to the diaphragmatic inflammation or infection or any other disease related to the diaphragm, which we will see later. So this is the referred pain due to the diaphragmatic disease. Now you should know that in the abdominal cavity we have peritoneum. So just below the diaphragm we also have the peritoneum, and this peritoneum is in continuation with the liver and the gallbladder there on the right hypochondrium. So if cholecystitis means inflammation of the gallbladder occurs, the peritoneum in the relation of the gallbladder will get inflamed, and the same inflammation can go just below the diaphragm because same peritoneum is continuing there. So if peritoneum over the diaphragm is getting irritated or inflamed, again the pain can go to the right shoulder. So in cholecystitis, pain can go to the right shoulder, and it can be caused due to the diaphragmatic irritation also. So you have to demarcate whether it is cholecystitis or anything related to the diaphragm if pain is there on the right shoulder. Now what is happening according to motor supply? So again talking about motor supply, right and left phrenic nerve is coming from the neck region, going through the thoracic inlet, then going to the thoracic cavity, and finally reaching around the pericardium of the heart and then supplying the diaphragm. Now it will pierce the diaphragm first. That is very important. Right and left phrenic nerve is not supplying the diaphragm from the above. They will first pierce the diaphragm, go below the diaphragm, and then from the inferior aspect of the diaphragm, phrenic nerve will supply. So in this way, diaphragm is getting supplied from the inferior aspect. That is very important. Now moving further. Arterial supply and venous drainage. So lot of things are there, but you don't have to remember everything, and it is very simple to remember. Anything named as phrenic, any artery will supply the diaphragm. So you can name as superior phrenic, above the diaphragm will supply the diaphragm. Inferior phrenic, below the diaphragm will supply the lower surface of the diaphragm. Now two more arteries with the name of phrenic, musculophrenic and pericardiacophrenic. So this is pericardiacophrenic, CO should be there, pericardiacophrenic arteries. Superior phrenic artery is direct branch of thoracic aorta. Musculophrenic and pericardiacophrenic arteries are coming from internal thoracic artery. So this is inside the thoracic cavity. So these will supply the upper surface of the diaphragm. And inferior phrenic artery is below means it is in the abdominal cavity, so it will directly come from abdominal aorta bilaterally, one on each side, and then they will supply the lower surface of diaphragm. Now the veins having the similar name, and they will go according to their location. So musculophrenic and pericardiophrenic will go to the internal thoracic vein, superior phrenic, and will go to the IVC. Lower surface, inferior phrenic, will go to the IVC, or it can go to the suprarenal vein. So this is about the arterial supply and the venous drainage of the diaphragm. Very simple. Anything related to the phrenic that will supply the diaphragm. Lymphatic drainage, very important. Don't underestimate the lymphatic drainage, because we all know that the carcinogenic metastatic pathway is mainly via the lymphatic system. So upper surface of the diaphragm will drain lymphatic drainage via the diaphragmatic lymph node, then going to the phrenic lymph node, and then to the parasternal and posterior mediastinal lymph node. So above upper surface, it is going to the thoracic cavity. So on both sides of the sternum we have parasternal lymph node, and posterior mediastinum has important lymph nodes, posterior mediastinal lymph node. So from upper surface they are going there. This parasternal group of lymph node is very important, because in relation to the mammary gland you must have studied that from both sides, medial side of the mammary gland, lymphatic drainage goes to the parasternal group of lymph node, and diaphragmatic lymphatic drainage is also going to the parasternal group of lymph node. So if these lymph nodes are enlarged, you have to demarcate whether disease is related to the mammary gland or something happening to the diaphragm. So this is very important. Lower surface will go to the lumbar lymph node. Simple. Now the important point here is lymphatic plexuses on superior and inferior surface of diaphragm will communicate with each other. Okay, so this is very important. So friends, moving further, openings of the diaphragm. Extremely important part of the diaphragm. If you don't study the openings of the diaphragm, then you have missed almost 80% of the diaphragm. So openings of diaphragm is very important. Here clearly we can see three important openings. Vena cava opening in the central tendon of the diaphragm, esophageal opening in the right crus of the diaphragm, and aortic opening behind the median arcuate ligament. This is median arcuate ligament. So behind the median arcuate ligament we have aortic opening. So these are the three major openings. Apart from these three major openings, we also have minor openings for a smaller structure, like left phrenic nerve will directly pierce the muscular part on the left side and will go below the diaphragm. Now this sternocostal triangle here, which is also known as Larry cleft. So here we have superior epigastric artery coming through this. So again this is minor opening. Through this small opening, superior epigastric artery will go to the abdominal wall inside the rectus sheath. So this is the another opening, small opening. Apart from these, we have also opening for hemiazygous veins, small opening on the left side. So we have many openings, major and minor openings, so that we have to know. And here you can see that we have medial arcuate and lateral arcuate ligament. So behind the medial arcuate ligament, adjacent to the vertebra, sympathetic chain will be there. So here the sympathetic chain will pass behind the medial arcuate ligament. Sympathetic chain will pass. So this is another minor opening on both sides, sympathetic chain. Also, you have studied some splanchnic nerves. In sympathetic supply to the abdominal viscera is mainly via the splanchnic nerves, greater, lesser and least splanchnic nerves. So they will also form minor opening on right and left side of diaphragm, and they will come through the diaphragm, will go to the abdomen and will supply the abdominal viscera. So greater, lesser and least splanchnic nerves are also forming the minor openings. Hope you have understood. Three major openings and many minor openings will be there. We will see further. This triangle is very important here. This is lumbocostal triangle. So on the posterolateral side of the diaphragm, you can see these small part where the diaphragm is not so much thick, because here it develops from the membrane. Embryologically, if you study, here the diaphragm is developing from the membrane and it is thin in respect to other part of diaphragm. So this region is known as lumbocostal triangle or Bochdalek triangle. So this triangle is very important. So we will see the application of this triangle later on. Hope you have understood. Moving further, again in this picture you can see nicely the inferior vena cava opening, esophageal opening and aortic opening. You can see the muscular part of the diaphragm and the central tendinous part trifoliate nicely. This whitish portion. Now, what we have discussed earlier, major openings of the diaphragm. Vena caval opening. Vertebral level are very important. The vertebral level of vena caval opening is thoracic 8 vertebra. Thoracic 8. How you will remember? Just remember vena cava. Vena cava. 8 letters. Vena cava. That's why T8. Simple. Esophageal opening. Esophagus. Count the number of letter in esophagus. It will come to 10. That's why T10. Aortic opening. You count the letter in thoracic aorta. It comes to 13. But we have only 12 thoracic vertebra. So T12. Simple. So openings of the diaphragm. Major openings. Vertebral levels. T8. 8 letters. T10. Esophagus. 10 letter. And T12. Aortic opening. So these are the vertebral levels. Now discussing more, vena caval opening is present in the central tendon, while the esophageal opening is present in right crus of the diaphragm, and T12 aortic opening is present behind the which ligament? Median arcuate ligament. Simple. Now you have to remember the structures also. What are the structure which is passing through these openings? So vena caval opening. Simple. Inferior vena cava will pass. Now, along with the inferior vena cava, we have right side of the pericardium. So along the pericardium, we have right phrenic nerve which is passing. So it will pass through the vena caval opening, right phrenic nerve. Also the lymphatics which is coming from the liver will go to the mediastinal group of lymph node via these openings. Coming to the esophageal opening, esophagus will pass. Simple. On both sides of the esophagus, we have vagus nerve, right and left vagus, which is going to supply the abdominal viscera, parasympathetic supply. So right and left vagus nerve will pass along the esophagus through the esophageal opening. Now lower part of the esophagus is supplied by arteries coming from the abdominal region. Those are left gastric vessels. So esophageal branch of left gastric vessels will also pass through the esophageal opening, and so as the lymphatics of the lower third of the esophagus. Aortic opening. Aorta will pass. Along with that, we have azygous vein and the thoracic duct. which is passing through this opening ATA, aorta, thoracic duct and azygous vein. So these three structures will pass through the aortic opening. So this is about the major openings of the diaphragm. Moving further, minor openings. So as we have discussed, superior epigastric vessel will pass through the posterior to the sternum, Larry space. Through that, superior epigastric artery and vein will pass. Lower 5 intercostal nerves and vessel will pierce the diaphragm and also pass through the small openings. Musculophrenic vessels will also pass. Lowermost part, subcostal nerve and vessel will pass through the small opening just behind the lateral arcuate ligament. So these structure will pass behind the lateral arcuate ligament. Sympathetic trunk, as we discussed, it will pass behind the medial arcuate ligament, medial, over the psoas major muscle, thickening. So medial arcuate ligament, behind that sympathetic trunk will pass. And through a small opening, as we discussed, sympathetic supply to the abdominal viscera via the splanchnic nerves. So greater, lesser and least splanchnic nerve will also pass, both on right and left side, through small openings of the diaphragm. Right phrenic is passing through the inferior vena cava opening, but the left phrenic nerve will directly pierce the left dome of diaphragm. So left phrenic nerve will pass directly through a small opening in the left dome of diaphragm. And same as the hemiazygous vein, which is coming from the abdomen going towards the thoracic cavity, hemiazygous vein will also pass on the left side through the left dome of diaphragm. So these are the minor openings of the diaphragm. Hope it is clear to you. Moving further. Here we can nicely see median arcuate ligament. Behind that is the aortic opening and you can see aorta is passing. Laterally, what we can see? Medial arcuate ligament. Here sympathetic trunk will pass. More laterally, lateral arcuate ligament. Here subcostal nerves and vessels will pass. Very good. Moving further. Clinical points. Most important nowadays are the clinical points related to the diaphragm. First is the hiccup. Intermittent contraction of the diaphragm due to irritation may be caused due to acidity, gastroesophageal reflux disease, heavy smoking. Intermittent contraction of diaphragm occurs with closure of the glottis. That's why during hiccup we have the specific sound due to closure of the glottis. So this is about the hiccup, intermittent contraction of the diaphragm due to phrenic nerve irritation or due to gastroesophageal reflux disease, acidity, anything can cause irritation that can cause intermittent contraction of the diaphragm, causing hiccup. Now phrenic nerve can get damaged during neck surgery or in the surgery of the thoracic region. So if one side phrenic nerve is damaged, what will happen? Diaphragm of that side will not be able to contract. So that part of the diaphragm will be slightly elevated. So if right phrenic is damaged, right side diaphragm will be elevated as compared to the left side. If left side is damaged, left side will be elevated as compared to the right side. So this is about the section of the phrenic nerve. Referred pain from the diaphragm we discussed, it can go to the shoulder region and we have to demarcate it from the cholecystitis pain, which can cause irritation of the peritoneum below the diaphragm. So you have to demarcate between both the points. Referred pain. Referred pain of diaphragm can also go to the subcostal region because the peripheral part is supplied by the intercostal nerves, lower 6 intercostal nerves. Now, diaphragm can get traumatic rupture. If diaphragm is traumatically ruptured, what will happen? Abdominal viscera can go through that opening and go to the thoracic region. So herniation of viscera can occur. Hiatus hernia, usually found in adult life, due to the esophageal opening. If it is not working properly, or muscular part of right crus of diaphragm is not proper if muscular part is loose in that region of the esophageal opening, abdominal viscera in continuation with esophagus is the stomach, so that can go from the abdomen to the thoracic cavity causing the hiatus hernia, and it can be of two types, sliding type or rolling type. Sliding means along with the esophagus stomach is going up along the length, so that is the sliding type. Rolling type means gastroesophageal junction is at its place, but by side of the esophagus part of the stomach is going inside the thoracic cavity, so this is the rolling type of the hiatus hernia. Now Bochdalek hernia, as you have seen posterolaterally we have lumbocostal triangle, weak part of the diaphragm developing from membrane. So if in that region, if congenital weakness is there, abdominal viscera can go inside the thoracic cavity from the posterolateral part, so that causes the Bochdalek hernia. What is Morgagnian hernia? Diaphragm is also taking origin from Giffard process. So sternocostal openings, Larry space, anteriorly small openings where the superior epigastric vessel is passing. If that opening is dilated, abdominal viscera again can go up in that region. So that is causing the Morgagnian hernia. How you can remember? Morgagnian behind the sternum, M for medial. So medially if hernia is happening, that is the Morgagnian hernia, congenital type. Means from the birth it is causing. Weakness is there since birth. Bochdalek, posterolateral, lumbocostal triangle, B for bugle, bugle में है. So that is posterolaterally weakness is there, that is causing Bochdalek hernia. So hope it is clear. Moving further. Here you can see the herniation of abdominal viscera in the thoracic cavity. Congenital diaphragmatic hernia. Loops of intestine we can see in the thoracic cavity that causes compression on the lungs, and that will cause lung tissue to shrink, means development will be weak of the lung tissue. Hypoplasia, lung hypoplasia will occur. Again the same thing, loops of intestine in inside the thoracic cavity, this black portion which you can see. Now here you can see the hiatus hernia. Sliding means along the esophagus stomach is going up, and here by side of the esophagus stomach is going up in the thoracic cavity. So this is rolling type of hernia, or you can say paraesophageal type of hiatus hernia. So these are the clinical points related to the diaphragm. So these clinical points you should keep in mind and try to explain anatomically how it is going to happen. Hope this is clear to you. So that is all about the diaphragm. Hope you have understood the anatomy of diaphragm, how it is taking origin, how nerve supply is going, artery is going, what are the clinical points, referred pain of the diaphragm. So that is all about the today's lecture. Thank you very much. Keep liking and keep subscribing my channel. I will be coming with more and more videos conceptualizing everything clearly, neat and clean, and also giving points for MCQ for your PG entrance examination. Thank you very much.